Hello everyone and welcome to another lecture of pulmonary medicine. Today we are going to talk about diffuse parenchymal lung diseases or interstitial lung diseases. Now we all know these diseases, they're not very common like COPD or asthma, but they tend to be asked a lot. There are more than 300 interstitial lung diseases, but today we are gonna subcategorize these and condense them into small group diseases. As you can see here, they can be categorized as known or unknown causes. All right. The most common unknown cause is idiopathic pulmonary fibrosis. All right. Now this presents 20% of all interstitial lung diseases. Okay, and there are different patterns of these idiopathic interstitial pneumonia, such as non-specific interstitial pneumonitis, such as the ones that seen in connective tissue diseases. This could be they can be associated to a cause, or they can be idiopathic in themselves. This combative interstitial pneumonia, bronchiolitis-related pneumonia, these ones, they're associated with smoking. Acute interstitial pneumonia associated with acute unknown idiopathic ARDS. Okay, lymphocytic interstitial pneumonia associated with cysts. Also, cryptogenic interstitial pneumonia as well, also known as cryptogenic organizing pneumonia with consolidations and stuff. LAM, lymphangioliomyomatosis, Langerhans associated with smoking as well. The acute eosinophilic pneumonia, all of these, they can be idiopathic. Some of them, they can be also due a cause. All right. The non-causes, these are the ones that are associated with occupations, such as asbestosis, silicosis, borreliosis. We'll talk about these at the end of the lecture. Treatment, all right, the ones associated with treatment like radiation, oxygen, bleomycin, and the association of bleomycin with oxygen. Methotrexate, amiodarone, nitrofurantoin. These drugs, they, once you see them in the stem of the question of pulmonary question, you have immediately to think about interstitial lung disease. Hypersensitivity pneumonitis, the ones that are associated with the birds fans, the fanciers, the breeders, all right, the farmer's lung, the hot tub, all of this, the Japanese house, all right. These ones, they are a separate entity. In the past, they used to think of these as IPF, but now they know the cause and these antigens, and they separate these as well-known causes. And then there is the systemic and autoimmune diseases such as rheumatoid arthritis, scleroderma, dermatomyositis, Sjogren's, all right, and the vascular diseases, microscopic cholangitis, etc. And the sarcoidosis, we talked about sarcoidosis as a separate lecture, all right, and we put it here because it's not, it's still considered due to unknown cause, but they already marked some of the causes. They think of it as more of an occupational disease, all right. Now these are of some of these abbreviations if you don't know them. IPF, or idiopathic pulmonary fibrosis, is the most common idiopathic interstitial pneumonia that has the worst prognosis of all ILDs. Now, out of all of these, okay, the worst prognosis is with IPF. Okay, 4 years survival. Okay, the death usually, in 4 years, 5 years, maximum 10 years from the diagnosis of the disease. Right? Scleroderma also has bad prognosis if it's associated with interstitial lung disease. There are some of these are attributed to smoking. The ones we marked here as disquamative, the bronchiolitis, Langerhans histiocytosis. They tend to have obstructive plus restrictive patterns in pulmonary function tests. Now, as you can see here, IPF now considered to be only 20% of all interstitial lung diseases, but still the most common cause of the idiopathic ones. Okay, hypersensitivity pneumonitis, sarcoidosis, connective tissue diseases, and then there are all the other causes and the pneumoconiosis. As you can see, only 10%. You have to know the interstitium. Now we know the interstitium is this area, the blue area, that the area that separates the alveoli from the vessel at which the gases, diffuse. Okay, but also you have to know that the interstitium extends until the distal airways. Okay, that's why sometimes, like in sarcoidosis and the ones with smoking, the lung disease can lead to obstructive pattern. Okay. As you can see here is the interstitium. All right, there are different sites of the interstitium. Some, as we will know later, some diseases are associated with more of of a site, like for example the peribronchovascular interstitium. If it's more affected, maybe you think of it as the hypersensitivity pneumonitis. Subpleural is usually UIP. Okay, usual interstitial pneumonia associated with IPF or rheumatoid arthritis sometimes. Now, if you have to like to break all interstitial lung diseases into some points that they have in common, these are the ones. Okay. Now, all interstitial lung diseases they usually have progressive dyspnea on exertion. Okay, mostly they are chronic. They can be acute, they can be subacute. Some of them can be acute and subacute, but most of them are chronic and they progress to chronicity. Right, bilateral reticulonodular or ground glass or honeycombing on high resolution CT. It's very important to use the high resolution CT. Mostly restrictive on pulmonary function tests, but as well we talked about when they can be obstructive plus restrictive, known as mixed. All right, they have the interstitium, as we said, is the place where the fusion occurs, so its affection leads to decreased DLCO. All right, and there is a widened AA gradient. Now they can be acute, as you said, with inflammation, and they can progress to fibrosis on histology. Okay, these ground glass opacities, as you can see, and these are the honeycombing and the reticular opacities. See, in here it's subpleural, in here more like posterior and around the bronchovascular, right? Idiopathic pulmonary fibrosis. Now it's a spontaneous form of the interstitial pneumonia. Usually or mostly it's UIP. Okay, usual interstitial pneumonia on high resolution CT, or usual interstitial pneumonitis on the pathological slide. Right, it's the most common cause, as we said, of unknown or idiopathic pneumonias. Okay, the risk factors, they can be genetic causes, they can be due to aging. Now we know that most of the times with IPF, it's people with age above 50, above 60, male smokers. 80% of IPFs, they come up with GERD, gastroesophageal reflux disease. The pathogenesis, there are many mechanisms, a lot of mechanisms, and they're still studied. There's a genetic susceptibility, of course. There is aging, telomeric attrition, where it's becoming shorter and shorter with time. All right, senescence. All right, mitochondrial dysfunction, and many environmental factors and growth factors leading to release of inflammatory and cytokines. Okay, and the activation of myofibroblasts to do the fibrosis at the end of this disease. Now, the pathological affection, they can be UIP. It's heterogeneous appearance, as you can see here. All right, some of the lung is affected here, affected, and some are normal, as you can see. So it's heterogeneous, it's not homogeneous. All right, honeycombing pattern, you can see like here, this is honeycombing. It can be seen on CT as well. All right, fibroblastic foci, as you can see here, these are fibroblastic foci, no granulomas. Very important to know this. Now this diagram clears some of the pathogenesis. Now it's mostly, as you said, associated with smoking, microaspiration, like as we said in GERD, occupational, viral, mechanical air pollution. They can lead to fibroblastic activation through different mechanisms, as you can see here. And as you can see here, there are many drugs that are still on testing, and there are two approved: the nintedanib and the birfenidone. All right, all these mechanisms lead to myofibroblastic differentiation, matrix deposition, and the senescence associated secretion with down regulation of some mRNA genes. Okay, mitochondrial also dysfunction plays a role, shortening or attrition of the telomeres, the ends of the chromosomes. All right. Now, UIP is not specific for IPF. Okay. If UIP and there's an obvious cause, like there is, for example, uh, rheumatoid arthritis. Okay. Now, this UIP is because of rheumatoid arthritis, and you diagnose this as connective tissue disease related interstitial lung disease, not because of idiopathic. Now, if there is no cause plus UIP, either from the high resolution CT or from the biopsy, now you can then you can diagnose IPF. Okay. So here, as you can see, the history and the exposure plays an important role, as you have to ask the patient everything about the exposures, his work, where do you work, all right? What kind of material do you deal with? What kind of animals? What kind of substances? Is there do you use hot tubs? All the stuff that you saw on the table, you have to do examination for the skin, for the system. Is there any autoimmune disease? Is there some kind of joint disease? Okay. uh, Usually present, as you said, with slow onset chronic exertional dyspnea, months to years, chronic dry cough, inspiratory fine crackles, velcro like, as you can listen to this one, velcro like. Fine inspiratory crackles. All right. If it's chronic enough, they can lead to cyanosis, clubbing of fingers, of course. Now, the interstitium is the part where the vessels exchange gases. So they can lead to pulmonary congestion and pulmonary hypertension at the end, leading to cor pulmonale, heart failure. Now, IPF is a carcinogenic. All right. There's an increased risk of lung cancer due to IPF. Chest X-ray, mostly reticular obesities. Okay, it can be also reticulonodular. On high resolution CT, as we said, it's UIP pattern. Now, what's a UIP pattern? It's subpleural. All right. Basal, in the base of the lung. All right. They can be reticular, or you can see also honeycombing, right, with or without traction bronchiectasis. You don't have to have these ones, but the presence of traction bronchiectasis, it tells us that the fibrosis is extensive. Okay. Plus, no non-UIP features. There are some features that will exclude UIP, for example, or make the diagnosis of likely, or it's being UIP is unlikely or less likely. That's maybe when you do the biopsy. For example, there is extensive consolidations, cysts, mosaic attenuation. These are usually associated, as we will know later, with different diseases. For example, consolidation as in cryptogenic or organizing pneumonias, cysts as in LAM, mosaic attenuation as in hypersensitivity pneumonitis. Pulmonary function tests, they can be, as you said, restrictive pattern mostly. Decrease DLCO, 6-minute walk test. A lot of us do this test. You let the patient walk for 6 minutes, and if he desaturates, that's chronic exertional dyspnea. All right. And bronchoalveolar lavage is not that helpful unless in some diseases like where you see like eosinophils, for example, acute eosinophilic pneumonia, and Langerhans-Steele histiocytosis. Also to rule out infection if you suspect infection. Now, biopsy, they can exclude the other interstitial lung diseases, such as the ones associated with granulomas, as sarcoidosis, for example. As chest X-ray, you see here volume reduction. You see reticular, bilateral reticular obesities. All right, this is the CT. This subpleural affection here. You see more of honeycombing. Okay. Also here, subpleural honeycombing. You see traction bronchiectasis. Traction bronchiectasis here, more extensive maybe. All right. Diagnosis. As you said, as we said, the history and the clinical picture are important to rule out all possible causes. And then we proceed with imaging, chest X-ray and high resolution CT. And then if we still didn't get the UIP, you can do lung biopsy and pathology. And if you see UIP, it's IPF. If not, as we will discuss later, you look for another, or first you have to look for another diagnosis. If there is no another diagnosis, you think maybe this is IPF. IPF exacerbations, they can occur. The patient can desaturate acutely. They can be hypoxemic respiratory failure. okay, more of ground glass opacities. Now you have to realize that the ground glass opacities, they are the early stages, they are the acute stage that they are associated with inflammation. Okay, now if they are associated with inflammation, then the treatment is steroids. Okay, we use steroids for ground glass opacities for the inflammation part of the disease. But if it's already fibrosis, you cannot use steroids. They're not helpful. You use the antifibrotics. Maybe the antifibrotics we will discuss, they prevent the exacerbations, and they slow the progression of the disease. All right. Complications, they can be pulmonary hypertension, pulmonary embolism. Now you have to have a high degree of suspicion in such cases. Okay. As we said, the prognosis is bad in IPF. Survival is 4 years on average. Some can live for a year, two, some for 10 maybe, but not more than that maybe. Exacerbations, as we said, they worsen the prognosis. Okay. The antifibrotics, they don't make the prognosis better, but they can slow the progression of the disease. As you can see here, for antifibrotics, you can use home oxygen therapy if it desaturates below 88%, and there is no role for steroids. There is no role for steroids in IPF. Okay, because IPF is an end stage disease. All right, it's more about the fibrosis. It's more about the honeycombing, and all right, pulmonary rehabilitation will only like make your life better, but it's not gonna decrease the or make the lung any better. All right. Lung transplantation is the definite treatment. At the end, they will all reach that point where the lung will fail and you need transplantation. So you refer the IPF patients immediately once diagnosed IPF. If the patient is diagnosed with IPF, it's in itself is an indication to refer for lung transplantation. Now, this doesn't mean you put him on a list. It's just you refer him to that. The antifibrotics, the pirfenidone, it's a multi-mechanism drug. It's basically antifibrotic. All right, these are all the mechanisms. The most common side effect is nausea, anorexia. All right, photosensitivity. All right, skin rashes, increased liver function tests, and nintedanib, a tyrosine kinase inhibitor that inhibits these factors. All right, we talked about in the pathogenesis. All right, vascular endothelial growth factor, the platelet-derived growth factor, and the fibroblastic growth factor. The most common side effect of nintedanib is diarrhea. So maybe you have to give antidiarrheal with this drug. And also as well, it can lead to increased liver function tests. Now, the antifibrotics, as we said, they slow the progression of the disease, all right? And they slow the decline in FVC by 50%. They decrease the rate of exacerbations, all right? But can they lead to decreased mortality? Maybe they can lead to decreased mortality in the sense that they slow the progression of the disease, all right? But they don't directly like make the lung like better, like they treat the disease. No, it just slows it down. Okay. The role of antacids, all the patients with IPF get PPIs, all right, but they're not well studied. They just since we talked about the GERD and its association, 80% of IPFs, they have GERD. Lung transplantation, as said, once UIP is confirmed, you refer for transplantation. Otherwise, if FVC is below 80%, you also refer for lung transplantation. Now, this is the algorithm. You suspect IPF, you have to look for causes. All right. If there is a cause, specific cause, now you don't think this is IPF, you have to do hydrogen and you evaluate. You look maybe for some serology. You have to look for a specific occupational cause, maybe. All right. If there's specific diagnosis, okay, that's it. We're done. If no, there's no apparent cause, maybe you do the high resolution CT and you see UIP. All right, this is IPF. Okay, if it's not UIP or it's still not conclusive, maybe some UIP features, maybe not some non-specific IP features. So you do the biopsy, you do the bronchoalveolar lavage. If you find another diagnosis from the biopsy and this stuff, eosinophils, etc., this is your diagnosis. If still there is no specific diagnosis, then we say this is IPF. Probably in the future we'll be finding more reasons to differentiate these IPFs, Organizing pneumonias or cryptogenic organizing pneumonias, previously known as BOOP. Okay, they can be acute, rapidly progressive inflammation with patchy and inflammatory granulations. Okay, they're not responsive to antibiotics. Now if you see an image like this, you maybe think this is pneumonia. You give him a course of antibiotics, the patient does not improve. All right. Now, this is maybe not due to some sort of bacterial pneumonia, all right, or some usual pneumonia, as we know. Maybe this is a cryptogenic organizing pneumonia. Maybe it's idiopathic. Maybe it's due to a secondary cause that we don't know. Okay, maybe it's due to a drug. Maybe it's post-infectious. Maybe it's due to connective tissue disease. Maybe it's due to radiation. All right. The hallmark here is you see these inflammatory granules on slides. All right, they're a collection of macrophages. All right, there is an intact lung architecture. The patient presents in like flu-like symptoms like dyspnea, cough, fever. This is pneumonia. Bilateral lung crackles, but as we said, they're not responsive to antibiotics. You do the high resolution CT, you see these ground glass opacities. They can be triangular in shape with the base to the periphery and the apex to bronchivascular. They can be like band-like here, as you can see here. They're very responsive to corticosteroids. So corticosteroids is a treatment even in recurrent cases. Rare cystic lung disease. Now, you just have to differentiate that. The difference between Langerhans cell histiocytosis and leiomyomatosis is not in the CT. You're not gonna find that different because both can lead to cysts, as you can see, cystic formations in both of them. Both they can lead to pneumothorax, even though pneumothorax in lymphangiomyomatosis is more common. Maybe it's likely to be recurrent. If you see some chylothorax, maybe this is due to lymphangiomyomatosis, as we said, with the obstruction of the lymphatic drainage. Now, what's the difference? The difference is that Langerhans is associated more with smoking, all right, while LAM is associated with in young women usually, all right, or with tuberous sclerosis complex, even in men sometimes with tuberous sclerosis. There are some systemic affection. These are not specific lung diseases only. They are systemic diseases. In Langerhans cell histiocytosis, you see these osteolytic bone lesions. You can see skin and scalp eruptions, endocrinal involvement. With LAM, you see tuberous sclerosis, you see adenopathy, angiolipoma is very common. If you see this in a question that they mention angiomyolipoma, okay, in a patient that complains of lung disease, you have to think this is maybe LAM. All right. For biopsy here, you can do biopsies maybe, but in LAM we have the VEGF. All right. D. This is specific for LAM. It's not sensitive. If it's negative, you don't rule out the disease, but if it's positive, there you go. It is your diagnosis. Okay. In terms of treatment, now Langerhans is just, as you said, is associated with smoking, so the treatment is smoking cessation. All right. But here we have rapamycin, sirolimus. It's an mTOR inhibitor, a macrolide. All right. It stabilizes the lung function and has better quality of life. Does not decrease mortality. They all progress, and the ultimate treatment is lung transplantation. Some rare inherited diseases such as the Hermansky-Budlak syndrome, rare autosomal, oculocutaneous albinism, platelet dysfunction, all right, lung disease in young man, all right, mostly in people from Puerto Rico. It's familial, all right. These are the cysts. And there's the pneumothorax. Hypersensitivity pneumonitis or extrinsic allergic alveolitis. Now, this is a non-IgE. This is not IgE. This is IgG, all right, mediated non-caseating granulomatous lung disease. All right, this sensitization and subsequent recurrent exposure lead to the specific antigen. Now, these antigens, as we said, they can be like from animals, from birds, from bacteria, molds, and fungi. Rarely they can be from inorganic stuff, maybe. All right, so it's non-IgE, non-eosinophilic. You have to differentiate these between them and the eosinophilic causes. All right, this is not eosinophilic. It's not associated with eosinophilia. All right, you have to know that the antigen size is very small. Now, why this is important, because the small antigen, the small size of the antigen, make it capable of reaching the distal airways, the alveoli, all right, and inducing an immune response to that distal interstitium. All right, the causes, they can be a lot. They're unlimited, from the farmer's lung, like the moldy hay and grains, the bacteria, the fungi, associated with that, the Japanese summer house, associated with a lot of these microbes, tuberculosis, the moldy cork, the people collecting that, they can be moldy, and they with sensitization and subsequent recurrences, they can lead to a chronic disease. All right, hot tubs are associated with MAC, Mycobacterium avium complex, swimming pools, birds, breeders, fanciers. All right, as we said, a lot of these you can read here about. Some inorganic particulates, maybe chemical workers. All right, people working with dyes, glues, paints. All right, foams. And I watch a lot. I like to watch these people doing the epoxy tables. And they every day, like, they scrub some of the surfaces. I always wonder, are these people wearing masks? Maybe after a lot of years, these ones will get hypersensitivity pneumonitis. All right. They can be acute and subacute or chronic. Now, the chronic one is the end stage with fibrosis. Okay. And if it's fibrosis, usually there is no specific treatment. If it's still acute, maybe you do some steroids. The characteristic high resolution CT is the upper lung mosaic attenuation, as you can see here. Places where there's air trapping, when you image that during expiration, you see this mosaic attenuation. You see the ground glass opacities. Where are they? They're peribronchovascular inside. All right. And then, as we said, if since they affect the airways, the upper, the distal airways, they can have a restrictive plus obstructive pattern pulmonary function test. All right, the treatment is just to avoid the cause. All right, corticosteroids maybe some benefit if it's acute, subacute, but if it's chronic, it's no use. All right, and finally, lung transplantation. Drug-induced interstitial lung disease. We talked about these. We talked about the methotrexate, amiodarone, nitrofurantoin, bleomycin, oxygen. Right, bleomycin with oxygen is sometimes you have to decrease the oxygen for people with bleomycin, because they form reactive oxygen species, and they can lead to drug interstitial lung disease. Now, this is diagnosis of exclusion. All right, they can lead to fibrosis. As we said, the treatment is drug withdrawal. You stop the drug. All right, radiation pneumonitis, same thing. If it's acute, you do steroids. If it's fibrosis, it's not responsive. All right, it's dose dependent. It's usually 6 weeks to 6 months of exposure. All right, ground glass opacities and consolidations, they respond to steroids, and if they're present. If it's already fibrosis, there is no use. Okay, connective tissue diseases. Now, the most common abnormality is not UIP, it's NSIP. Now, UIP is still kind of present in connective tissue disease, but the most common ones are non-specific interstitial pneumonia. All right, and UIP is more associated with rheumatoid arthritis. The other connective tissue disease is NSIP. Okay, the lung disease may precede the connective tissue disease, becomes before the connective tissue disease, as maybe you can let's say you don't find a reason. You ask the patient every history you can ask about, and you do the high resolution CT, and you look and you see UIP. The pathologist reports this as UIP. Now, as we said in the algorithm, this is IPF. Now, are you going to assume that's UIP, IPF, because IPF is end stage disease. Okay, you're not gonna give that person more than the antifibrotics, all right? But this patient maybe sometimes will, in few months, will start to show some rheumatoid arthritis disease, all right? Now this makes the diagnosis different, and the treatment is different. You're gonna treat these ones with steroids and immunosuppressives such as mycophenolate mofetil. That's why sometimes people tend to, if they're not sure it's IPF, IPF usually takes a long time to diagnose. Because first maybe you give a trial of steroids. You see maybe if they're really responsive, okay, because this is changing the treatment, all right, and the diagnosis, okay. Lung nodules, pleuritis, effusions, pulmonary hypertension, all associated with lung disease related to connective tissue disease. Acute eosinophilic pneumonia due to smoking, vaping, all right, dusts, all right. This is an acute ARDS, okay. Diffuse bilateral infiltrates eosinophilia, or more than 25% on bronchoalveolar lavage. Differential diagnosis, eosinophilic stuff like parasitic, fungal, drug reactions, cancer, all right. Treatment, they improve with steroids. Microscopic polyangiitis, it's a small vessel vasculitis. It's usually affects the pulmonary system more than the renal one, right? If you compare it to the GPA, granulomatous polyangiitis, Wegener's granulomatosis, formerly known as Wegener's granulomatosis, this is pulmonary renal. They can lead to rapid progressive glomerulonephritis as well. Now, in microscopic polyangiitis, the lung affection is usually lower respiratory, alveolar hemorrhage, fibrosis, but in GPA, it's upper and lower. You can see sinusitis, saddle nose deformities, otitis, subglottic stenosis, okay, as well some of the lower affections, all right. Here you can see neuropathy, cutaneous leucoclastic vasculitis, all right. The diagnosis in GPA, it's Cianca. In MPA, it's Pianca, okay. And the treatment is corticosteroids with immunosuppression. EGPA is eosinophilic granulomatosis with polyangiitis. We talked about this, or we will talk about this with the asthma, okay, because it's associated with asthma. Pneumoconiosis. Now, the most common one is silicosis, all right. It's associated with sandblasting in miners, all right, on the surfaces, not like underground mines, all right. Quartz, rocks, glass workers, all right. Now, silicosis is carcinogenic and it's associated with TB. You have to rule out TB if you suspect silicosis. You can see the silica crystals. You can see the acidular hyaline collagen on imaging. Now, you're going to see upper lung small nodules, okay. You can see eggshell calcification, very characteristic in silicosis. Coal workers and pneumoconiosis, people who deal with coal, dust, graphite, people working underground mines, all right. Kaplan syndrome, it's rheumatoid arthritis plus large pulmonary nodules due to co-workers pneumoconiosis. Hard metals, people working with cobalt, they can present with giant cell interstitial pneumonitis. With iron, you see dust, macules, and siderosis. Beryliosis, people working in computer factories, aeronautics, All right, they present like sarcoidosis. All right, byssinosis, people working with cotton. Stenosis, people working with tin. Asbestosis lung disease. Now, asbestos lung disease is usually affects the lower lung lobes, not like the others, right? And it's usually people working with buildings, construction, cement, the firefighters, because they also deal with houses, people building stuff, building automotive, industrial stuff, brakes, friction materials, building ships, Now, there is a lung disease associated with that. They can range from uh, interstitial lung disease to plaques, calcified bilateral pleural plaques, pleural thickening, all right, effusions, mesothelioma. Now, mesothelioma is a specific cancer, specifically due to asbestosis. All right, it's almost exclusive to asbestosis, and maybe develops 10, 20 years after the exposure. All right, the most common cancer of asbestos is bronchogenic carcinoma. This is exclusive to asbestos, but it's not the most common. The most common is bronchogenic carcinoma, and it's potentiated with smoking. Smoking plus asbestosis dramatically increases the risk of lung cancer. All right, bronchogenic carcinoma, not mesothelioma. All right, rounded atelectasis. Now this is thickened visceral pleura that leads to lung collapse. All right, and maybe some smoking, it's considered nowadays as a occupational disease. People just smoking like all the time, and they can present with a lot of, as we know, obstructive disease, emphysema, acute bronchitis, whatever, but also chronic bronchitis, whatever, but also not exclusive to that, they can present with interstitial lung diseases. All right, what are these interstitial lung diseases associated with smoking? They're respiratory bronchiolitis related interstitial lung disease, disquamative interstitial pneumonia, pulmonary Langerhans cell histiocytosis, acute eosinophilic pneumonia, combined pulmonary fibrosis and emphysema, and also all the other cancers with and pathological marks like carcinoids and bronchiolitis and stuff. Okay, that's it for today. Thank you for listening, and until another lecture, see you.